Hello, this will be a question and answer session regarding adrenals, and this will be based on the guidelines which I've discussed in the previous videos. So the first question is regarding a 50-year-old man who complains of abdominal pain, and imaging shows metastatic adrenal carcinoma. So which of the following drugs will improve the prognosis in his case? A. Amintaglutamide, B. Ketoconazole, C. Meterapone, D. Mitotane, E. Sunitinib. So the answer is Mitotane. So Mitotane has been shown to prolong survival in high-risk patients. It's usually given for 2 years. So it is an inducer of CYP3A4. So what is the effect of this? A significant amount of hydrocortisone, which is given for replacement, is immediately inactivated. Thus, patients on mitotane treatment might require increased glucocorticoid replacement than the standard dose. Also, it can interact with other drugs because of the induction of the CYP3A4. For example, statins, macrolides, benzodiazepines, etc. So it is to be monitored by experienced doctors, and there is a risk of glucocorticoid deficiency. Also, it could also have unwanted side effects like neurotoxic effects, trouble talking, trouble walking. But it could resolve when it is stopped. Other side effects are diarrhea, fatigue, rashes, etc., and could give rise to a moderate elevation of transaminases too. So Mitotane, it is a first-line treatment in metastatic adrenal cancer. So in patients with rapidly progressive disease who are on cytotoxic chemotherapy, Mitotane is used. The cytotoxic chemotherapy is called the Carotid regimen, which includes cisplatin, etoposide, doxorubicin, and along with Mitotane. The newer treatment options are PI3 kinase inhibitors and IGF receptor antagonists, which are under investigation. So the next case is a 20-year-old boy who has been found to have a carotid body tumor. His father and his uncle had paragangliomas. So what will be the probable etiology for his situation? Is it a MEN2 syndrome? Is it NF? Is it a VHL syndrome? Is it Carney complex, or is it SDHB mutation? Well, the carotid body tumor, the head and neck tumors, are usually associated with the SDHP mutation. So the right answer is 4. So the next question is a 35-year-old lady who has high blood pressure and palpitations. CT reveals paraganglioma. So which of the following mutations are associated with the paraganglioma? A. 21 hydroxylase. B. Loss of function of MAX. C. Menin. D. TMM127. E. VHL mutation. Well, the right answer is VHL mutation. Which I shall explain it to you later, why other mutations are excluded. So let's come to the next question. A 68-year-old lady is suspected to have secondary hypertension. Blood pressure is 165 over 1/95. BMI is 26. Physical exam is fine. She's taking amlodipine 10 mg. Electrolytes are okay, RFTs are fine. Aldosterone is quite high and the renin is low. So she undergoes an aldosterone suppression test which fails to suppress aldosterone. What would be your next step? Is it a CT? Or will you do an MIBG scan? Or will you do the AVS, adrenal sampling? Or will you stop the amlodipine and repeat the ARR test? Or would you do a postural stimulation test? Well, if you go back to the question, it shows that aldosterone is quite high and the plasma renin is low. And aldosterone suppression test fails to suppress aldosterone. So the confirmatory test for aldosteronoma is positive now. So what will you do next? You will go with the CT scan to know what is the cause of the increased production of aldosterone, whether it's an aldosterone secreting adenoma or adrenocortical carcinoma. So the right answer is CT. Adrenal venous sampling is used for lateralization and MIBG is used for diagnosis of pheochromocytoma. There is no need to stop amlodipine and repeat the renin aldosterone ratio because CCBs don't affect the ARR ratio. There is no need to do a postural stimulation test as a test has been done to confirm the aldosterone excess. So coming to the next question, 77-year-old gentleman on doxycycline for hypertension has persistent hypokalemia. So the renin to aldosterone ratio is 850. So what is the next step? Will you stop doxycycline and start ACE inhibitor? Will you start him on a potassium supplement? Will you stop the doxycycline and start spironolactone? Or will you start a thiazide diuretic after stopping the doxycycline? Or will you stop the doxycycline and leave him alone? So the plasma renin activity to aldosterone ratio is elevated. In other words, he could have an aldosterone secreting tumor, and that could be the reason why he's having persistent hypokalemia. Doxycycline doesn't affect the ARR ratio, so there is no need to stop the doxycycline, whereas spironolactone will definitely affect it. So spironolactone need not be started on, but rather he could be started on a potassium supplement to correct the hypokalemia, and the renin to aldosterone ratio could be repeated. So that would be quite helpful. In this context. So again, why you need to give the potassium supplements, because aldosterone concentrations can fall and there could be an increase in renin, so it could have a false negative result. So that's why you try to give the oral potassium supplement to avoid any false negative. I'm sorry, I think the slide had skipped. I was just telling for this patient. Okay, let's go to the next patient. A 74-year-old Indian man is admitted to the ITU after head trauma. On the third day, his 24-hour urinary free cortisol values are high. So, what is the most appropriate step for this man? Will you check the midnight cortisol values? Will you do a low dose dexamethasone suppression test? Will you do a overnight dexamethasone suppression test? or will you leave him free? There is no need to evaluate the cortisol secretion. Or will you repeat the 24-hour urinary free cortisol? The answer is that you don't need to do anything for this patient. The answer is 4. No need to evaluate cortisol secretion at this stage. In critically ill patients, CRH, cortisol, ACTH, all the levels increase due to his illness. Also, the cortisol binding globulin and albumin levels fall. That will cause a rise in the free cortisol levels. So the cortisol levels during acute illnesses rise, and they don't represent any hypersecretion. So once the illness is taken care of, once he's free of the illness, his cortisol will come back to the normal. So a 60-year-old man who complains of abdominal pain and he has undergone a CT scan which shows gallstones, but along with the gallstone there's a 3 centimeter left adrenal adenoma. On examination, his vitals are normal, U's and E's are normal, the complete blood count is fine. What will you do for him? A. 24-hour urine collection for catecholamines. B. 24-hour urine collection for urine-free cortisol. C. MRI. D. No further investigations. And E. Plasma renin to aldosterone activity. So the answer is 1. 24-hour urine collection for catecholamines. Well, the adrenal CT shows an adrenal incidentuloma. So you don't want to miss a pheochromocytoma, because if you miss it, it will be catastrophic. So you will do the 24-hour urine collection for the catecholamines. An MRI, it doesn't have any advantage over the CT in this case. So you will screen for the catecholamines. So next question is a 13-year-old gentleman who presents with a difficult to treat hypertension. He's got a 5-year history of hypertension, and he takes amlodipine, lisinopril, and HCTC. Yet, his systolic blood pressure is elevated consistently. His blood pressure is 170/94, and the BMI is 45, so he is morbidly obese. All the blood tests are normal except for potassium, which is on the lower side. So what will be the next step? Will you do an MRI? Will you go with an MIBG? Will you do a 24-hour urine catecholamine test? Will you do a plasma renin to aldosterone ratio, the PRA to aldo ratio, or it's also called the aldosterone to renin ratio in the United States? So either way, will you do that, or will you stop the HCTC and check the ARR? Well, the answer is perform the ARR on current treatment. Because amlodipine and HCTC doesn't affect much. But if he is on a beta blocker, it can definitely cause false positives for him. In fact, the lisinopril may increase the sensitivity of the test, because it is associated with false negative test results. But the beta blocker and the spironolactone could produce a false positive result. So it's mandatory that you need to stop the spironolactone at least 6 weeks before, because it's a long-acting drug, and you need to stop the beta blocker 2 weeks prior to the test. So the correct answer is 4. So 40-year-old man with abdominal pain has MRI, which shows a 6 centimeter adrenal mass. Urine-free cortisol, urine catecholamines, and plasma renin activity to aldosterone ratio are all normal. So what is the most appropriate action for this patient? Will you do an MRI in 3 months? Will you do it in an year? Will you do it in 6 months? Or will you reassure and discharge? Or is the patient for surgery? So the answer is surgery, because it's an adrenal more than 4 centimeter. So it's a large adrenal and you have to proceed with surgery. There is no point in doing a repeat MRI. So the next case is a 44-year-old female who's investigated for high blood pressure, weight gain and weakness. So a low dose dexamethasone suppression test confirms Cushing's. Urinary free cortisol is quite high and ACTH is low. MRI shows bilateral adrenal hyperplasia and pituitary imaging is normal. So what next? Will you do a surgery for bilateral adrenalectomy? Will you explore the pituitary more? Will you do an inferior petrosal venous sampling, venous sinus sampling? Will you treat with drugs like metropone or mitotane? So in this patient, you can see that she has features of Cushing's syndrome, even though her CT scan shows, or the MRI shows, bilateral adrenal hyperplasia. If she was asymptomatic, we will treat her medically with MR receptor antagonists. But here, she is symptomatic, and her Cushing's syndrome could increase her mortality. So ideally, we will refer her for surgery and for a bilateral adrenalectomy, and she will be on glucocorticoid supplementation following that. So here is another lady, 66-year-old, Cushing's syndrome, now presents with weight gain, weakness and thinning of the skin. And CT shows a 9 centimeter left adrenal tumor. Surgery is done, adrenals are removed, histology shows adrenal carcinoma. The patient is steroid dependent and is prescribed hydrocortisone twice daily. Oral dexamethasone suppression, overnight dexamethasone suppression test shows very low cortisol. So in this case of adrenal carcinoma, which drug is known to prolong the period of remission? cisplatin, ketoconazole, metropon, or mitotane. So I think we have done a question similar to this before. So mitotane is one of the drugs which shows promising effects in adrenal carcinoma. So it is given usually for 2 years, and it is known to prolong the period of remission. Whereas ketoconazole is given in steroid-dependent Cushing's, where you're trying to wean off the steroids. So next question is a 20-year-old male who has extra-adrenal pheochromocytoma. Physical exam is okay, and there is no family history of any pheochromocytoma. So what genetic tests will you be performing for this patient? Is it a BRAC? Is it an FGF1? Is it an NF type 1 or type 2? Or is it an SDH type? Will you do screen for SDH mutations B and D? So the right answer is 5, SDH, B and D, because extra-adrenal pheochromocytoma is the clue here. So if you find any patient has got extra-adrenal pheochromocytoma, definitely you need to do the SDH, B and D. B is known to have associated with Mets and malignancy. So next question is a 50-year-old man who has abdominal pain, and the provisional diagnosis is gallstones, which is confirmed by ultrasound. But ultrasound also shows a suspicious lesion in the adrenal. So he's later he is taken up for a CT scan, which shows a 2.3 centimeter left-sided lesion. He's asymptomatic as far as adrenal lesion is concerned. That means he doesn't show any signs of hormonal hyperactivity. So the only drug he's taking is Adrenal 25 mg for his hypertension. Investigations show 24-hour urine-free cortisol normal, urine-free adrenaline normal, urine-free noradrenaline normal, plasma renin activity to normal is normal, aldosterone is normal, but the urine-free meta-adrenaline is elevated. So which of the following is likely diagnosis? Adrenal carcinoma, aldosteronoma, Cushing syndrome, incidentaloma with factitious results, or pheochromocytoma? The answer is 5, pheochromocytoma. If you go back to the question, you can see that the free meta-adrenaline is elevated. The PRA to aldosterone ratio is normal. So that rules out the aldosteroma, or even if it's an adrenal carcinoma secreting the aldosterone, that rules out that. And it's a 2.5 centimeter left adrenal lesion, and it has no features of any malignancy, so that rules out adrenal carcinoma as well. There are no features, and the urine free cortisol is also normal. There are no features to suggest any Cushing's syndrome. Well, you could think about factitious results, but urine free adrenaline is elevated, which is not factitious. In fact, the adrenaline and the noradrenaline is normal, but the meta-adrenaline could be elevated. Since the adrenaline and the noradrenaline could be metabolized to meta-adrenaline, so that's why their levels are normal and the meta-adrenaline levels are elevated. So the answer is a pheochromocytoma. So, a 40-year-old man having resistant hypertension for about 10 years is on atenolol, bendrofluoroside, doxazosin, and amlodipine, and ramipril too. So his vitals show that he's got elevated blood pressure, heart sounds are okay, potassium is low. So he is supposed to have an aldosterone plasma renin activity to be assayed. So which is the most important medication that you need to stop before doing the aldosterone renin ratio? Is it amlodipine? Is it atenolol? Is it bendrofluoroside? Is it doxazosin? Or is it ramipril? Well, I've already told before, amlodipine and doxazosin won't affect the AR ratio. Diuretics could cause hypokalemia. Ramipril could cause a false negative test, so it could actually increase the sensitivity, but the beta blocker and spironolactone could definitely produce a false positive. So the beta blocker atenolol should be stopped 2 weeks prior to the test, and spironolactone should be stopped 6 weeks prior to the test. So the answer is atenolol. Well, I had told you that I will discuss this question later, so because I was not very clear about the choices, so that's why I thought I'll review it later. So a 34-year-old lady shows CT shows paraganglioma. So which of the following mutations is most likely to be associated with this paraganglioma? So is it 21-hydroxylase? No. That's associated with CAH or adrenal hyperplasia. Is it menin mutation? No. That could be with neurofibromatosis type 1, not the type 2. So that leaves behind the VHL, the TMEM127, and the loss of function of MAX mutation. Well, the loss of function of MAX mutation, the TMEM127 mutation, the VHL mutation, could all be associated with the paragangliomas. But out of this, the VHL is the most common, so the answer would be the VHL. So thank you for being with me for this presentation. I'll come up with more questions. I hope this presentation helped you. Bye.